One of the physicians during that training said, well, we didn't learn this in medical school and it wasn't in my residency, and this needs to be made available to all physicians that are currently practicing or in training. And that was really hopeful and such a heartfelt testimony from a physician that we trained.
This is Countermeasures, brought to you by Emergent. Join us as we explore the shifting, complex world of the opioid crisis. In each episode, we'll hear from makers of positive change as they recount personal narratives of loss and perseverance and offer a way forward to a better future. As the opioid epidemic has changed and evolved, our understanding and responses have had to change as well. But have our systems kept up? Barriers to care, stigma, and other factors all impact people struggling with opioid dependency when it comes to accessing the help they need. In this episode, we explore how the healthcare and social systems in the United States and Canada have responded to the epidemic, and what is being done to ensure that professionals on the front line are equipped with the knowledge and skills they need to best support people and have a meaningful impact.
My name is Jessica Hulsey, and I'm the founder and executive director of the Addiction Policy Forum. APF is a national nonprofit organization, and though I've been in the field for a long time, we really wanted to address a lot of the major gaps that still existed in the field of addiction, including bringing patients and families to the table.
Founded in 2015, the Addiction Policy Forum, or APF, is a nationwide nonprofit organization dedicated to eliminating addiction as a major health problem. This work includes helping patients and families in crisis, expanding prevention and early intervention programs, and increasing education among policymakers, medical professionals, and the wider public.
I got involved in the addiction field because of the impact that addiction has on my own family. My younger years, when I was a child, was a lot of disruption and difficulty really caused by my parents struggling with the substance use disorder. So I was homeless and in and out of the foster care system, and then finally raised by my maternal grandparents when my mom went to prison for addiction-related issues. And so at 15, I got involved in a prevention organization, wanting to sort of use that, lessons learned and lived experience and the knowledge of how disruptive addiction can be in a family and a community, really try to make a change and sort of help improve how we respond to this. Since then, I've worked in prevention, treatment, in drug policy, came to DC when I was 17, and have been doing this work. This is really my life's work. I call Addiction Policy Forum a love letter I write to my mom every day. I lost my mom when she was only 50 to addiction-related health consequences, though she'd had a number of years in recovery. And I lost my dad, who struggled with opioid use disorder and crack cocaine, so stimulant use disorder, when he was only 48 years old. So I try to turn that tragedy and that difficulty into maybe improving and helping what happens when addiction hits a family, when it hits a community. How can we respond and mobilize in a different way? And all of that sort of passion and experience that my family has gone through really fuels my work.
Social worker Shannon McLoughlin has worked with marginalized populations for most of her career. She works in Hamilton, Ontario, a Canadian city that has been heavily impacted by the opioid epidemic. Shannon has seen how difficult it can be for those with opioid dependency to access the social and medical systems we take for granted.
There are a lot of barriers to service. For instance, lots of marginalized people have had a bad experience historically with the medical health profession, either being having people be rude to them, having them be dismissed because they're dirty, maybe they've shown up with a garbage bag that has their stuff in it. People who are in the throes of an addiction, their lives are often disorganized. And being able to get to an appointment on time, consistently, or even to have the ability to get to that place, to have the money or the transportation, is often a real barrier. So there's barriers of fear There's barriers of access. There's barriers of historical bad interaction with the health profession previously. A lot of people who are on the street, they don't have a fixed address. So there are, at least in the city that I live in, there are outreach workers who will connect with people where they're at and help them get to the appointments. People are really trying to bring those barriers down, but still there are people who fall through the cracks and aren't seen. Also, mental health often complicates it. You'll often see a mental health issue with the addiction, with the opioid use or whatever people are using. And so together, that makes it very difficult. There could be paranoia, there could be total distrust, which is often based in real reality for these people.
Jessica and the Addiction Policy Forum have conducted research on this issue and have found that barriers still exist for many people. They have also seen the importance of holistic approaches to recovery and access to a wide variety of resources to help overcome barriers.
We did find some very consistent themes, these pain points or barriers to sort of finding treatment and recovery. They included the stigma. We're back to that thing of what people face. Stigma coming from healthcare providers, family members, friends, and others, and other really tangible barriers, such as really long wait times to finding treatments, to finding services, not understanding where to get an assessment or how to navigate this very complicated process, insurance barriers and the high costs of programs, and lots of policies that were really difficult to navigate, like fail first and prior authorization. We also found barriers on sort of the tangible resources that people need to have accessible to them to be successful and healthy and well, such as transportation, access to food and housing and employment and resources. All of these sort of pieces that can be really big hurdles to getting the care that you need. Other barriers included not knowing what level of care was appropriate for them, for yourself, and not knowing where to go to sort of start that process. And it's really, I think, important that we take the lead from our patients, whether those have an active use disorder or in recovery or currently seeking treatment, so we can make improvements to this process and have low barrier access points to improve how we bring people into care. In no other space in our healthcare system, when we look at chronic health conditions, do we make it so difficult to start care when a diagnosis is made. And so that's where we should be heading in our goal. How long does it take a diabetes patient or a cancer patient or a heart disease patient to start linking up with the tests, with the doctors, the services, and the treatments that they need?
There is progress being made to lower barriers to care in both the United States and Canada. However, there is still stigma present that affects people's ability to get care.
So say someone tries to access the ER, I would say yes, that there is stigma baked into that system. I think now those systems are, at least some of them, are trying to look at themselves and perhaps crumble that cookie and maybe make a new one. But the language, oh, we got a frequent flyer, he can sit there for a while, he's here all the time. Well, that's pretty disrespectful, but I know I've heard that language. They have legitimate reasons for being there. And, but often I think people, ERs are busy, fast paced, they're crowded. I don't know anywhere where you don't sit for a really long time. And I think in those situations, people's hidden bias may come out a little easier because you're stressed and worn down.
Jessica is happy to see programs emerge that are designed to break down some of these issues.
There are some innovations that are out there that are doing such a great job with this. I'm a huge fan of the bridge clinics, so these low barrier access points to start treatment. Boston Medical Center has really developed an amazing program there. So we're really talking about the availability of treatment on demand and starting care immediately. bringing in different clinicians and different services, but also inducting and initiating medications for opioid use disorder very quickly, and then continuing that person and that patient with the care that they need. So I think we can look towards these sort of spotlights and beacons of hope and programs that are popping up all over the country and figure out how we can expand and replicate them so we start to change these barrier points.
Jessica and the team at the Addiction Policy Forum advocate for evidence-based programs to help bridge some of the gaps and help lower barriers. And both she and Shannon believe multidisciplinary teams are a step in the right direction.
We have amazing programs in the criminal justice settings in Cincinnati, Ohio. They have this amazing program where they're providing evidence-based treatment services to individuals who are incarcerated in their county jail, who have any type of substance use disorder. They have a combination of medications that are available, peer recovery coaches that are available during incarceration, and also really focus on that transition to the community, which is a high-risk time. And they're starting to build recovery pods. So you have a residential unit that provides an extra level of care while people are incarcerated. And then we have harm reduction, recovery support services, recovery community organizations, and supports that provide people with that long-term care support that they need to manage their chronic health condition. So there's so many innovations that are available. I think it should keep us very hopeful, but also focused on how do we replicate these innovations and take them to scale. I also love the QRT models that we're seeing pop up in the addiction space, and that stands for quick response teams. And it's kind of a growing model, and it's not just about that initial 911 response, but also when you see someone, let's say in your emergency department for a non-fatal overdose, when we are able to reverse an overdose, and then places like Kentucky and Ohio, when you have teams that go out to provide services to that individual, because we know that those who've had a non-fatal overdose are at risk for another one. And we want to follow up that naloxone administration with connection to services. And you have these multidisciplinary teams, all over the country that are doing active outreach to make sure that we build that bridge to care after we've reversed an overdose. And I love that work that they're doing. We should be expanding and taking to scale quick response teams as well.
I think multidisciplinary teams work very well. So you have a psychiatrist, you have nurses, you have peer workers. I think peer workers, people of lived experience who can speak to people from a place that I can't, are really important at normalizing the individual's feelings and truly understanding what it's like. Social workers, we do practical things like make referrals, and depending on your role, you might pick up someone and take them to an appointment. You might do in-house visits to make sure that, their groceries and stuff, they're being fed. But I think multidisciplinary teams work very well because you pull the person, it treats people holistically. They need a social worker perhaps for some therapy to talk about how they're feeling.
The language and images we use impact stigma and how individuals with opioid or substance use disorder are treated by the medical system.
We've started in the field doing a lot around language and changing our language. It sort of really matters how we talk about people who are struggling with addiction or in recovery. It sort of signals, how we value individuals in a certain space. So changing words like addict and junkie to a person or an individual with a substance use disorder or a person in recovery from a substance use disorder, changing language like a positive or negative urine screen is not a clean or dirty screen, right? Because that dirty piece, saying that to someone who has a positive urinalysis test is really weighted down with blame and shame and judgment. And that language piece can really signal that we see this through that health lens.
Shannon also emphasizes the importance of language.
I think that language is appropriate to all different situations, but everybody wants to be treated with respect, and everybody deserves to be treated with respect. A lot of people aren't treated with respect for whatever reason it is. But that is going to alienate people and not feel that, make them feel welcome, make them feel very wary, and also not inclined to engage. They very may well be judged by whoever is seeing them, whoever is triaging them.
When Jessica began her work, there was still a lack of understanding that addiction was a disease and not a choice. There have been steps in the right direction, but the stigma that exists today is still rooted in these beliefs. Understanding how stigma continues to impact responses to the opioid epidemic continues to be important. While stigma may not be as overt as it once was, myths and misinformation are still prevalent.
What I've learned doing this work for so long is the pieces that are underneath stigma, right? So the items and the areas that we need to correct to eradicate stigma are really about misinformation, lack of knowledge, and myths that really exist when it comes to SUD. Myths like this is a moral failing, that this is a character issue, that sort of devalues the entire population of individuals, not just who are in recovery from a substance use disorder or seeking treatment, but devalues and sort of alienates individuals who use substances and are struggling or have this chronic health condition. We also have these myths and misinformation that sort of feed into that, or feed into sort of our need to distance ourselves from this entire population, right? And that's what we really need to correct. We want people to be reaching out, to offering support, to being helpers in that connection to care, and not pushing our entire population away. As my mom and dad struggled with SUD, so they started with alcohol use disorder and cannabis and some pills and escalated into heroin and crack cocaine. There's lots of, between family systems and educators and jail systems and prison systems and child welfare and employers that they lost jobs from. There's lots of people they came in contact with, but we don't understand addiction in terms of how we can all be supportive and have a role in responding. And that misinformation sort of means that we miss these opportunities to engage. So when we start to correct misinformation, that this is a health condition, it does start by behaviors, but humans participate in a lot of risky behaviors, from eating things we shouldn't eat, smoking, risky sex, driving too fast, all these different things that can lead to injury or harm. But understanding addiction through a similar lens, understanding that some of the behaviors that we define addiction as are actually symptoms of a brain disorder, and really reinforcing that people do recover, treatment works. We have medications with like a 75% rate of reductions of fatality. Could you imagine if we had a medication for cancer or heart disease that reduced your chances of death by 75, like 60 to 75%? There would be lines around the pharmacy and the hospital for those meds, and yet they're underutilized. So when we deconstruct misinformation and we replace it with science-backed, real information from a health lens, we really start to deconstruct and take away that stigma and replace it with a more compassionate healthcare-based response.
Shannon is also hopeful that things are moving in the right direction. She works with students at McMaster Medical School to understand the biases they may not know they even have, so that they do not carry them forward with them when they begin to practice.
I think it's about helping people who perhaps have not had exposure to some of the folks that they will be treating, depending on where they choose to go in their career, but to look at the assumptions that you have. Person who has feelings and maybe had a family and doesn't have them anymore. Maybe they had their kids taken away, or maybe they're really struggling. Maybe they're in a intimate partner violence. And so you don't know. And so I think it's teaching students, the medical profession of the future, to approach with curiosity and no judgment, which is admittedly difficult to do, but that's part of what school is, you learn how to do brain surgery, but you also learn how to see people as people, not as addicts. And also, this is not to say that this is widespread, that every medical professional, every social worker, every outreach worker. No, it's like anything. There's different, people are different. People have different attitudes. They have different thoughts. They have different ways of approaching. But sometimes I think it can be kind of overwhelming. And if you see the same person in ER time and time and time again, and you think, well, why are they here? Some people, it's a safe place for them, to be perfectly honest. They come in because somebody says hi to them. Not to say that they're not there for some medical reason, but also they might be there for emotional and social reasons.
Jessica and the Addiction Policy Forum have also been providing training to healthcare professionals, and the programs are effective.
We've been surprised about the reception of some of our education and, stigma reduction efforts among healthcare providers. We were just on the ground at a hospital doing a training with physicians and nurses and even researchers in the room, and providing more science-backed healthcare-related information about SUD. One of the physicians during that training said, well, we didn't learn this in medical school, and it wasn't in my residency, and this needs to be made available to all physicians that are currently practicing or in training. And that was really hopeful and such a heartfelt testimony from a physician that we trained. So I think there is an openness. Sometimes when we're out doing trainings, we do encounter certain rooms or certain practitioners who might be attached or very connected to some of the old misinformation or way of doing business. But when you sit with folks and convey the science, right, and there's a huge gap in how we've relayed this information to so many practitioners in our field. When you take the time to sit with people and go through what we've learned and where we're going and what innovations are available, I have yet to find a group of physicians, nurses, educators, those working on child welfare who aren't ready for that information so they can do a better job of helping people.
Jessica is hopeful for the future and is optimistic about what she sees.
We have sort of a changing constellation of barriers, such as fentanyl and its prevalence in our communities, which is creating more overdoses, more overdose fatalities. We have, but for every barrier or hurdle that we encounter in this field, we have 10 innovations, new treatments, new programs or innovations that can help patients and help families. So I think the good news is that when we follow the science, when we replicate what we know, what works, when we really focus on a healthcare response to addiction, we really can see significant improvements and reduce fatalities. So it's kind of a 1-2 punch with lots of difficulty, lots of tragedy. Most of us have someone we've lost or someone who's struggled with addiction in our lives. But if we really look to the programs and jurisdictions who are doing it right and implementing new ways to address addiction that have proven results, I think we can start to turn the tide.
Jessica and Shannon have both worked on the front line of this crisis. They have seen firsthand that it can be too easy for people to slip between the cracks or become alienated by our healthcare and social systems. But the future is promising. Employing evidence-based approaches to treatment like bridge clinics and multidisciplinary teams, continuing to educate to help break the stigma, and investing in prevention, intervention, and harm reduction are all moving us toward a future without accidental overdose. To learn more about the Addiction Policy Forum or about the opioid epidemic in Hamilton, Ontario, please visit the links in the description. Thank you for listening to this episode of Countermeasures. To learn more about what Emergent is doing to address public health threats like the opioid crisis, visit emergentbiosolutions.com. If this episode resonated with you, consider rating and reviewing Countermeasures on your preferred podcast platform.